Welcome to our final day of Microsoft Research Summit. We talked about some exciting topics yesterday, including research towards amplifying human creativity and productivity, and foundational work towards building the future of the cloud. For today's final plenary session, we'll join Peter Lee and many others for a wide-ranging discussion on the future of human health. We'll hear perspectives of practitioners working on the front lines of care, and we'll hear how researchers are using health data in new ways to advance the science. And importantly, we'll discuss work towards ensuring that the benefits of health technologies are more evenly distributed throughout society.
Hello, and welcome to the 2022 edition of the Microsoft Research Summit. I'm so pleased to introduce this plenary session on the future of human health. I'm Peter Lee. I lead Microsoft Research, including its labs around the world, as well as the incubation teams for new products and new lines of business that emerge from our research. Over the past few years, some of the most significant areas for both research and the creation of new businesses for Microsoft have been and continue to be in health and the life sciences. Our research in these areas is focused on the goal of empowering every person on the planet to live healthier, and for every organization to enable better health, wellness, and the advance of medical knowledge. To achieve this, we look for ways to help patients, clinicians, and organizations use science and technology to achieve and sustain the best possible health outcomes. Now, to achieve this, we look for ways to help patients, clinicians, and organizations use science and technology to achieve and sustain the best possible health outcomes. We've all seen compelling examples of the power of science and technology to improve human health. We've witnessed incredible progress, such as advances in computer vision systems that improve the diagnosis and treatment of cancer, natural language processing systems that help extract insights from unstructured medical notes or sift through the thousands of new medical research papers that get published every week. AI-powered clinical note-taking systems that reduce the administrative burden that leads to doctor burnout, and scientific advances in medical research in areas spanning genomics, drug discovery, and the social determinants of health. Supporting all of this have been some fantastic advances in modernizing health data standards and creating cloud-based platforms that support techniques such as machine learning, while at the same time guarding the privacy of patient data. Importantly, the data also shows, unfortunately, that the benefits of these scientific and technological advances are unevenly distributed throughout society. Today, healthcare delivery, medical research, biological understanding, and information technology are rapidly converging, but often remain stubbornly separated from the people and communities that often have the most to benefit from all this technological progress. Here at Microsoft, we want to help drive and accelerate that convergence while also ensuring that it benefits everyone. The future of this convergence, we think, will be healthcare that is more accessible to all, more data-driven, more proactive, and far more personalized than anything we have seen before. Now, over the past 10 to 15 years, healthcare has become very digital. In fact, in 2009, something like 15% of health records were in digital form, but today it's upwards of 90%. Medical devices have gone digital both in the hospital and at home. Genome and proteome sequencing is becoming accessible to more people, further increasing the amount of medical data we can use. New systems are emerging that listen in on doctor-patient conversations to relieve the burden of clinical note-taking, while at the same time improving the quality of digital data that is collected by electronic health record systems. Digital image processing has become the norm in radiology and is poised to become dominant in pathology over the next 3 to 5 years. And increasingly, digital data is connecting healthcare professionals to family members and informal caregivers, and in fact, connecting all the way back to medical researchers, opening up the possibility that emerging concepts such as real-world evidence will allow the medical profession to be a truly learning system for patients and their loved ones. The question now, and the challenge before all of us here today, is what can we do with all of this data in order to make all of this great positive potential a reality in all of our lives? How can we combine this data with technologies like AI and machine learning to improve human health? How can we build tools and services that make access to healthcare more equitable? Can we free clinicians to spend more time with their patients and provide people everywhere with the highly personalized and precisely targeted diagnostics and therapies they need? Can all of this data accelerate the pace of progress in medical research? Well, these are some of the questions that we'll try to address in today's plenary session. And in the Precision Health track that follows, we'll also explore many of these questions in greater depth. It's going to be a fascinating day. To start off, Mary Gray, who is a senior principal researcher at Microsoft Research and a respected academic and MacArthur Fellow, will lead a discussion about how we can ensure more equitable access to care for all people, including members of disadvantaged communities and marginalized groups in the United States and around the world. Greg Moore, Corporate Vice President of Microsoft Health, and Joe Petro, Executive Vice President of Nuance Communications, will conduct a lively discussion about how AI and other technologies are enhancing, augmenting, and accelerating the work of dedicated doctors, nurses, and other practitioners. Finally, I'll be talking with Seth Hain. He's the Senior Vice President for Research and Development at Epic, and we'll be talking about new approaches to data sharing in support of advancing medical research around the world. I hope you'll be intrigued and inspired by what we'll show you today.
Dr. Cameron Webb, thanks so much for joining us today. I really appreciate your time, and I really want to share with everybody how much expertise you're bringing to the table. So before we begin, I want to let everybody know the depth of perspective on health equity that you're offering us. As part of your work at the White House, you've examined how racism influences COVID response and how the virus affected historically marginalized communities. But before that, you were also a professor of medicine and public health sciences at University of Virginia School of Medicine. So I'm going to be asking you a bit about that. And you served as the director of health policy and equity. And I should mention you also were in the White House on the healthcare team during the Obama administration and must have seen some really challenging situations, not just in our country, but seeing the rise of Ebola in other parts of the world. So I know we both agree that so much of health equity is vital, not just to our own country's future, but it shapes the well-being of everyone around the world. It's a critical part of how we care for each other and continue through economic crisis, is that we are monitoring and managing health. So it's clear COVID exposed many of the gaps that exist in most local regional healthcare systems and the lack of connection between hospitals and community-based organizations. I would really like to start out asking you to give us your perspective based on your time as Director of Health Equity and Policy and just your own training as a doctor. What was the current state of health equity in the US before COVID?
Well, thanks so much for having me. And I think that, that's the right way to start this conversation. Where were we? So that we can get into where are we and where are we headed? And if you start with where were we, what I usually tell folks is that we had just kind of gotten the definitions right. For years we had been talking about health disparities, health disparities, health disparities. And I think that we were entering a phase where folks were talking more about health equity as really the goal and health disparities as the metric by which we gauge whether or not there's equity in any given health circumstance. And I think that was a really important change and a shift in the thinking, because it became less about just the sheer numbers and the outcomes. We know there are disparities in diabetes and heart disease and cancer mortality and infant mortality and maternal mortality, in pneumonia vaccination rates. There were so many areas where we saw these great disparities, HIV/AIDS and those outcomes. But what was different is we started to talk more about how did we get to those outcomes. We saw studies that showed us that only 10 to 20% of those outcomes are driven by health and healthcare, and the lion's share are driven by dynamics in communities, the places where you're born, grow, live, learn, eat, play, and pray. And so I think that's really where we were. We were at a point where we really had adopted this language of equity, this focus on thinking about the whole person in the context of the whole community. And even though we still saw those inequities, we understood that they were shaped and forged in community. And so when we stepped into this moment of pandemic, we quickly realized that this isn't a virus interfacing with individuals at a single point in time. It's a social experience of a virus. The dynamics that are driving some people to have increased levels of exposure in the broader dynamics in their community setting that drive them to be at greater risk for severe outcomes. I think all those things were very much so connected, but we were poised to have the right kind of conversations about equity because of really the evolution in the field over the last 20 years.
So as we're talking now, the White House has released news of the release of a new booster addressing Omicron. Could you just talk a little bit about what are you seeing as some of the most critical levers of change coming out of the White House, and what you think are the most important sources of federal guidance, regulation that are going to shape health equity? And I'm particularly interested in how to think about the access to data we now have, knowing how, again, unequal the impact of COVID was. Like, what are we going to be doing to make sure the data coming from the communities hit hardest serves them in the future?
Well, so in early September, that's when the CDC announced that we had a new updated vaccine. This is a booster that's again focused on the Omicron variant. It's a critical moment because it allows us to have a new tool that is meant to be more effective at keeping people safe. And the hope is that it's going to keep people safe a little bit longer. This would become part of an annual vaccination process instead of this ad hoc vaccination effort we've been having. But remembering that these new vaccines are actually in the context of a primary series that started in December of 2020, boosters that were rolling out throughout different parts of 2021 and into this year of 2022, the pediatric vaccination effort, all these different pieces of the vaccine effort. And so it was really important for us to say, well, what worked? What worked in the vaccination effort allowed us to close gaps between Black, white, and Latino individuals in that adult primary series within the first 9 months of that vaccination campaign. We knew those gaps were going to emerge because they're built on the back of the systemic inequality that exists in our society, and we have to navigate that thoughtfully. We have to make sure that we are pulling all the right levers to successfully navigate that. If we're not going to change the core dynamics. And the president, of course, is trying to change those core dynamics in community. But in the meantime, we had to navigate those. We were able to accomplish that with adult vaccination. With boosters, we were able to narrow those gaps for seniors getting their first booster. We saw that start to narrow for folks 50 to 64. So there's a lot of progress that was made. And with these newest vaccines, in terms of gaps by race, ethnicity, we know that there's a bit of a playbook. Is community-based organizations, faith-based organizations, community health workers, promotores de salud, making sure that they had the resources and tools that they need to be trusted messengers at the local level, to have those conversations, to do that engagement in a way that's authentic. There's people from community, in community, doing the work, and again, with seamless public health messaging at the local, state, and federal level to complement what's happening, at that point of interaction for those community workers, those community public health leaders. That really makes that's the key part of this effort. And so I think that's really what we aim to do as this effort continues on here in October, heading into November and December, when we expect we're going to see a rise in cases, because we've seen that the last few years. That's kind of when cold and flu season is at its worst as we head into the winter. We want to make sure that we say, here are the lessons we learned. Here's how we engaged community in the effort. But really what's critical about that is supporting, is the funding that went to community organizations, not just to do the work, but importantly, and to your point, to evaluate what works and what's effective. There are so many different tools that can go into that evaluation and help us get a sense of what is actually moving the needle on erasing or eliminating inequities. And I think that's what we're trying to tap into this time around, really trying to make sure we're sharing those promising practices that have the best success in eliminating those inequities. But every organization, every community needs different tools, but it always requires technological innovation, always requires having access to the data so that you can really quickly assimilate information about the folks you're aiming to serve. And I think that that's what we're going to see in this effort. That's what we saw in the previous efforts. And our hope is that we can save a lot more lives by really using those data in a thoughtful way.
Well, so you've said before that it really has been those community-based organizations that have been an incredibly important lever of change. Like, they really are the ones that can close the gap when it comes to talking with their community members about the importance of whether it's the boosters or just being able to continue to monitor their health. I'm curious how you feel about the need for kind of ongoing support, knowing that in most cases we don't have funding in place, certainly at the state level, the regional level, to be able to maintain these community-based organizations. It seems like the federal government's been able to do as much as it can, but what's your diagnosis, if you will, for what we need to do to be able to sustain the ongoing efforts of these very local organizations that are often members of their communities, maybe volunteering or stepping up, but are also being hit by the pandemic?
Well, it's a few things. States and localities have a better vantage point to really understand who are the groups and the organizations who are poised on the ground to have the greatest impact. They have those relationships. They know very specifically what works for Kansas, what works for North Carolina, what works for Massachusetts. So it's really important that they're close enough, to the ground and to the community. And you can get even more granular than that. Certainly, than the state level, you can get even more local. That's where the action happens. From a federal perspective, I really think that in some ways we're pace setters. We say this is really where we need to focus energy and support. And historically, the federal government has funded larger regional or national organizations who have infrastructure, who have resources to then go forward and do the work, or to do some sub-granting. I think what community organizations told us this time around is they said, fund us directly, give us the resources and tools that we need, and we'll show you what we can do. And in these first few years of the pandemic, what they showed us is that they're critical public health infrastructure. These are civic organizations who don't necessarily have, a public health mission inherently. But I think what we say is that health is in all policies. No matter what your mission is as a civic organization, there's a health lens that you can take to your work. And we proved that through this pandemic. And so, my thought, and when you say what's my diagnosis, it's that we all have to continue to invest in support in a meaningful way. And I think from a federal perspective, that's the grants we saw from CDC, from the Office of Minority Health, the support across HHS, the dollars going from the Department of Education and the USDA and Housing and Urban Development. Those are resources that have been critical to supporting public health work in this pandemic. And similarly, states have to continue to support it, because what happens on the ground, and I'm coming from a background of working in community, here in Central Virginia, what happens on the ground is that without the predictability of funding and support, it's really hard to plan your ongoing impact and intervention in your community. It's so important that you know what resources are coming your way, so you know how to staff up appropriately, how to train people to continue to do this work. And so I think that predictability in resources is going to be the key to these organizations building on what they've done through the pandemic and continue to have a really incredible impact on the health and well-being of their communities.
So, it's interesting because I think I'm hearing you say, like, this cluster of needs of these social drivers of health, from food security, mental health, housing, these basics, we tend to treat them as though they're not part of care. And from what I'm hearing you say, in terms of a way of addressing health equity, sustaining the push to balance the load of how we need to help people and being consistent of helping people. It sounds like we should be coordinating those services more. Can you say a bit more of places or examples you've seen where you've been able to see the empirical value of those organizations cooperatively working to support health and bridge to clinical settings? Like, what are the best examples for you of the connecting of that healthcare ecosystem?
There literally have been countless examples all across this pandemic. We say housing is health, for instance. And if you think about people experiencing homelessness, that's an area that's a congregate setting where the pandemic really can run rampant. But the work of community organizations to get emergency temporary housing for people experiencing homelessness, that's housing work but it's health work in this instance. The work of food, we saw how this pandemic exacerbated issues with food insecurity, and we knew how it challenged food banks because you couldn't have volunteers in the same way and you had supply chain problems. But the work of supporting that food infrastructure when you had an economic impact that led to increased food insecurity, yes, that's food work, but that was core public health work in that instance. Our education mandate, and you look at the impact, we just saw scores come back, and we saw the impact of the pandemic, a downward impact on performance in schools for kids, disproportionately in some of the same communities that are the hardest hit and face the highest risk from COVID-19. Yes, those educational dynamics are going to have an impact in the short term with regard to COVID, but they're also going to have long-term impacts on health and well-being, because we know there's a direct tie between educational attainment and adult health outcomes. And so all of these things are so intimately interwoven in community. I think that what works the best is that collective impact notion, the idea that all these organizations are working as part of a broader system to do great work at the community level, understand the dynamics from the same perspective as somebody does from a lived experiential standpoint. Somebody who's living in the community experiences housing, experiences food access, experiences education and income threats, and yes, health and healthcare. And when you put those all together, you're better poised to complement that work. I think we saw that play out in countless communities with the pandemic because organizations were really thrown together in the same space. Everybody was doing COVID work. I think as we move forward, as we continue to address COVID, but also as we address monkeypox, as we address flu, as we address the crisis that we continue to have with gun violence, as we address issues that we have with diabetes and other chronic disease, with obesity in our communities, with maternal mortality, there's a lot of opportunities for folks to say, this is part of our work, part of our mandate, and part of our core mission, and here's how we can do it together. So I think that what's great is that all over the country, community organizations saw what it means to work together, and they saw the very real impact of health outcome that you can drive by collaborating. I think that's a really special one.
Well, thanks so much for your time, Dr. Webb, and it's been a pleasure to talk with you.
It's been my pleasure. Thanks for having me.
Thank you.
Next up are Greg Moore, Corporate Vice President of Microsoft Health, and Joe Petro, Executive Vice President at Nuance Communications. They'll be exploring how advanced technologies are improving both patient care and the lives of hardworking practitioners.
Hi, everyone. My name is Greg Moore. I'm an engineer, a practicing physician, and I'm a corporate vice president for Microsoft Research, focusing on health and life sciences. I want to start today by painting a picture of our current healthcare system. Unfortunately, the system is in crisis with clinician burnout, staffing shortages, and tremendous financial pressures, all resulting in poor patient and provider experience. In fact, some of my physician colleagues are considering leaving the field of medicine, in part due to the tremendous administrative and documentation burdens put on them as part of the delivery of healthcare. In fact, I'm sure if any of you have had a doctor's appointment yourselves recently, you may have seen your nurse or physician furiously documenting on their computer with their back turned towards you. Hardly a good patient or a provider experience. Fortunately, the digital transformation of healthcare in response to COVID, the rapid advances in AI over the past few years, and the potential of precision medicine have given us the tools, the technologies, and now the experience we need to reimagine care and help rebuild this strained healthcare ecosystem post-pandemic. The urgent question we now face is how to bring all of these advances together to improve health outcomes, create better experiences for patients and clinicians, and boost affordability and access beyond the pandemic. I believe an important part of the answer to these challenges and the recovery we are all so much longing for may lie in how we apply an emerging set of advanced AI capabilities, generally referred to as ambient intelligence. We've been imagining this future of human health since 2019, when Microsoft Research and Nuance forged a new partnership to tackle some of the toughest challenges in healthcare with ambient intelligence. And I'm really thrilled here today to be joined by Joe Petro, my new colleague here at Microsoft and the CTO of Nuance. Joe?
Thank you, Greg. Over the last 10 to 15 years, Nuance has been hyper-focused on building technology that eases the burden placed on clinicians. And as Greg said, technology and solutions that literally turn the chair around. And this has been quite a journey. We've been living through the evolution of early AI to modern AI, of course, but we've also been living through the evolution from desktop computing to client server-based approaches. And today, we're fully in the phase of modern cloud computing. Today, when we talk about our focus in the future, as Greg said, we talk about the future being ambient intelligence. And Dragon Ambient Experience, or DAX, is an example of this idea where the environment itself is tooled with AI and the natural human-to-human interaction between the patient and the physician is restored. So yes, ambient intelligence as well also turns the chair around. A good question to ask is how we got here. If we go back to the beginning of the journey and we just look at something like automated or automatic speech recognition, or ASR, ASR was barely a shadow of what it is today back then at the beginning of the journey. If you look at ASR error rates, just as an example, we were running around 15% absolute error rates. And the technology was anchored on something like hidden Markov models and probabilistic and statistical methods. The question in those early days for us is, how do we survive the dark age? How do we continue to pour money on the problem and advance the state of the art? So we searched for problems that had commercial relevance. And in healthcare, we engaged human transcriptionists, somewhat sacrilegious as a technology company, but we had to have humans intervene because the ASR just wasn't good enough. And in the healthcare space, we paired up human transcriptionists with physicians. And this helped us build ground truth data sets that would eventually become more and more relevant for training our future engines. And in those early days, we were really just trying to develop a business. We had no idea how important those ground truth data sets would actually become. We also got into something called IVR, or interactive voice response. And what this allowed us to do is narrow the speech recognition vocabulary in such a way that the accuracy actually increased, and boom, we're in business and we have a funding source. And in the early part of the journey, our researchers committed to something very important. They advanced the state of the art in speech recognition by 15% relative error rate improvement per year. And after many years, we crossed this 90% accuracy level. And this was a magical inflection point. Physicians were willing to self-edit at that 90% level. Fast forward to today, we've got 65% of the physicians in the US using Nuance's speech recognition every day. And the accuracy level has actually achieved what we call the level of human agreeance. Modern AI, large neural nets, compute capacity in the cloud, we're all driving highly performant speech recognition, but something else happened along the way. We weren't smart enough to realize this at that moment in time, but we realized the doctor is actually holding the microphone. They're engaged with our technology every single day, every minute of every day. And we asked ourselves, what if we could do more than just speech recognition? What if we could inject intelligence into that experience? And we began doing this with traditional methods like regular expression-based approaches. And this evolved eventually to modern AI techniques. If we fast forward to today, we're at another inflection point. We're now developing these so-called end-to-end neural nets that include signal processing, speaker diarization, speech recognition, natural language understanding, and intelligence delivery, all incorporated in these singular, large, end-to-end neural networks. This was nearly impossible to imagine 10 years ago. And we're doing this exact same thing now with DAX. If you look at DAX, it's 2 transformer-based neural nets, 75 million parameters apiece. Literally in the next 30 to 60 days, we're releasing much larger versions of this, 275 million parameter versions of this same capability. And now with Microsoft, we are taking things even deeper, so to speak, and we're exploring how we inject their horizontal scale combined with our vertical stack. And this is introducing things like GPT-3, Turing, Megatron, these huge foundational models that are transfer trained on Nuance's vertical data corpus. And again, targeting this kind of completely seamless and natural experience for the doctor and the patients. And we're still, completely nascent in the nascent stages of all of this. I use the phrase modern AI, and it makes me kind of laugh every single time I say it, because 10 years from now, no one is going to be saying what we're doing today is modern, but this is kind of the way the story goes. The future promises that technology is going to move into the background and the human interaction will actually become the focus. And that's really what we're focused on. And this is basically the Star Trek vision that Gene Roddenberry laid out 50 years ago. He really did actually have it right. But what's important to realize is it was less about the sci-fi and less about the technology than it was about the humans. The technologies basically underpin the human interactions, and the humans basically stood on the shoulders of technology. And that's really what we're after here. So this is super nascent stuff. It's super exciting because the world needs technologies, thankfully for all technologists, thankfully for all of us. And we all just need to keep thinking big, and we need to keep working together and solving the challenges, all in the service of better health outcomes around the world. And some of the people you're going to hear from today are really at the forefront of this, and Greg and team are helping to lead that charge. So thank you. And Greg, I'll turn it back over to you.
Thanks, Joe. Really incredible to hear you talk about the technology that's already here today, and also your emphasis that we're just really scratching the surface of what's possible. In fact, you and I have recently reviewed developing voice marker applications in areas of depression and Parkinson's disease. Just incredible technology here that's going to be delivered by the ecosystem in the coming months and years as we move forward. And I think I'm even more excited about how this technology that we're already delivering now in the exam room is going to expand outside that exam room and even into the home. Focusing on what we're delivering today, I just have to share a personal experience. The first time that I actually demoed DAX to one of my physician colleagues, there was actually tears of joy, real tears, as they realized they could now turn that chair around, that documentation on the computer in the exam room, and focus their attention back on their patients. Really bringing joy back to medicine and restoring that patient-provider experience that was so near and dear to them. So incredible how we can use technology to actually positively transform healthcare and really get back to bring that joy back to medicine. And then going back to the early days, it's clear that we're in a world filled with sensors, and that includes the domains of health and healthcare. And as those sensors become ubiquitous across the health and healthcare ecosystem, I think we can imagine an entirely different future. In fact, one where a physician who today typically begins in a conversation with their patient by asking, "How have you been?" I can imagine the future your physician will begin a conversation with, "I see that you are." Just incredible power to actually advance healthcare and medicine as we go forward. So Joe, I really appreciate you giving us that glimpse, not only what's possible now, but really setting the context that we're just really scratching the surface. So thank you, Joe, for such a great conversation on how ambient intelligence is accelerating the future of human health. Later today, we'll have a dedicated session on ambient clinical intelligence and voice capture at the point of care. And there we'll welcome experts across the field to hear exciting use cases of the emerging technology as it goes forward.
Next, I'll be talking with Seth Hain, Senior Vice President for Research and Development at Epic, about new approaches to data sharing in support of medical research and clinical practice. I'm guessing that everyone in our audience has, of course, heard the term electronic health record, but maybe only a few are really familiar with what those really are. Can you briefly explain what is an electronic health record, why it's important, and what Epic's role is in this and in related technologies?
Certainly, yeah. Often folks don't even know when they're interacting with our software, which is sort of an interesting experience as a developer here. But more and more today, the places that people encounter our software is actually in their pocket through MyChart on their phone, which is a way for them to interact with their health system and to see their doctor. And in addition to using MyChart, our software is running in the clinics when they show up, say, with their child for a well-child check, as an example, where allergies and growth charts are being captured, and that information is then available for ongoing care for that individual, be it in the inpatient setting, say in the clinics, and then also, of course, the health systems use it as a platform for efficiently running their operations as well, interacting with insurance providers as an example, as well as exchanging medical data with other health systems. We have the lucky opportunity these days to work with around 500 health systems across the world, including 50 internationally outside of the United States. As sort of an interesting side note, we started actually as what we now describe as a database management system. It was a way to store data around the patient and build applications on top of them. And then over time, we started building more and more of those applications in the outpatient and inpatient space as an example. And then things like MyChart that I described earlier.
So you've been at Epic for quite a while. I think I saw online you've been there 17 years. Is that right?
It has been a while. Yes, 17 years.
So today you have the important position of overseeing all research and development at Epic, and really Epic, I think, is considered the most important company in electronic health records and digitization of health data. So over that 17-year period, in your view, what have been some of the most important changes in digital health that you've seen?
It's funny that the 15 years is almost the perfect time frame for the three things that came to mind as you were asking the question, because about 15 years ago, we set out to build something called Care Everywhere, which is a backbone for exchanging information between health systems. So, if I came out to Redmond as an example from here in Madison, Wisconsin, and had the unfortunate situation that I needed to end up in the emergency department, my allergies and medication lists would flow right into that system automatically, and people would have access to it. These days, that network does around 10 million exchanges daily, with about half of those moving between health systems that use our software to systems that don't, as an example. So we started building that 15 years ago, and the first patient, Francine, that got to experience that, she said we could use her name. It had her record exchanged between two organizations in California. So that was the first one that comes to mind. I think, more recently with the pandemic, we have seen a dramatic uptick in the number of individuals, patients using MyChart to connect with their physicians, be it for medication refills or a video visit, or, simply checking on their vaccination statuses as an example, now having over 150 million folks using that in their pocket. And then one I've been pretty directly involved in, you and I've chatted about it quite a bit over the last few years, has been around embedding artificial intelligence into the point of care. We're getting ready for our user group meeting here, and I was reviewing the statistics in advance of it, and I was a little bit surprised to see we have now broken over 100 models that customers created themselves in use in the system.
Wow.
And over 1,000 models in use across the entire community, including those that we created as well. So it's neat to see that stuff being put into practice at scale.
Part of the excitement of having you here on the Microsoft Research Summit is to see if we can delve a little bit into where computing research might be the most important for the future of healthcare. And so I'd like to dive in a little bit and maybe understand a little better the relevance of ideas and techniques like machine learning, artificial intelligence, other data analysis techniques. How do you see those ideas from computer science becoming important and relevant in healthcare delivery and in medical research? And maybe not just only things like machine learning and AI, but other computing ideas in cloud computing, security and privacy, human-computer interaction. What would you want our audience, who are primarily computer science researchers, to really understand in terms of what's important here?
The first thing that really comes to mind, and this heavily intersects the topic around machine learning and putting it into practice, is having folks be students of the deep user experience across how healthcare is delivered. Because as we approach the computer science challenges around how do we put this technology into practice, understanding how information is captured throughout a visit, As an example, when somebody shows up in the emergency department, there's a rapid set of information and vitals collected by nurses, but it's only limited in regards to what is captured through, say, an entire inpatient stay. And so figuring out what is that intervention point where I can predict, for example, if that person may need a bed in the hospital. That's an important challenge right now around capacity in hospitals. And then put it into a spot in the nurse's workflow so that they can take action on it. So I bring that up as an example because from our perspective and from a development perspective, we always start with what is the workflow in the intervention point, and then back into how do we use machine learning models as an example to inform that point of care and help folks make more informed decisions. Oftentimes we see things like cloud computing as an example as a method of delivering changes and updates to that technology more rapidly. That's one key piece of it. I think the other one, and it might be, it's an interesting area for ongoing research, is using the power behind the cloud to localize machine learning models to individual health systems. This is something we do with our cognitive computing platform today, and provides a way to adapt those models to the local environments and the patients that those organizations care for. We work with a broad swath of folks from federally qualified health systems to rural hospitals to very dense populated areas across, say, New York or San Francisco as an example. And so being able to tailor those models and be able to spin up the compute and then back down for those models to perform optimally in those settings is key.
You've really been, I think, the instigator and the intellectual leader, and this has led to a growing and accelerating amount of medical research being posted on the website epicresearch.org, which is just really fascinating to dive into. So let's tell the audience a little bit about what this project is and what's going on right now.
Certainly, and I do want to emphasize it truly is a community effort. It is an effort both of a number of developers and clinicians here on campus, as well as the broader informatics community across Epic. And what we've done together has been to pull together a data set that now exceeds 150 million patients. There's over 1,000 hospitals represented in the data set, and just broke 22,000 clinics that are also part of it as an example. And the way that this works is that as organizations, health systems that use our software choose to participate in Cosmos, their data becomes part of this rich research data set. And as part of it, they get access to do research as well. The goals of this effort are first to really gain insights that can be valuable at the point of care and embed those pieces back into physicians' workflows to help inform the care they give to patients and work alongside them on, say, how different treatments have led to an improved outcomes for similar populations. The second key aspect is accelerating that pace of healthcare innovation around both discovery from a therapeutics perspective, but then also certainly from a workflow perspective. And the third is really to encourage collaboration across the peer group. There's a couple of different tools that folks use for accessing and exploring the data in Cosmos. The first one is a business intelligence tool we call Slicer Dicer that gives your everyday physician that might have a hunch the opportunity to hop into the Cosmos data set and explore whether or not that condition they've seen with their patient is as prevalent as they might have thought, as an example. And then more recently, we have released a series of data science tools built around Python notebooks that folks can go explore and build their own models and do deeper research and publish papers based on. The entire experience is really built around and on top of an environment that we've doubled down from a security perspective. It uses the same hosting architectures that we use for health systems that use our software as well.
Yeah.
And I think it is important to highlight the community aspect of this from the perspective of the governing council, because the way that we set this up, there are 13 elected members from across the healthcare community that govern that. These are individuals whose organizations participate in Cosmos, and they create the rules of the road for how that data is used. It does not leave that secure enclave. Obviously, the research shows up on occasion on everything from Twitter to published research as well, in addition to epicresearch.org. But that governing council really gives organizations and patients the confidence that that data will be treated with the respect that it deserves and used to inform care going forward to make patients' lives better.
What an incredible day it's been so far. Thank you for being a part of it. I hope you've gained some new insights about the intersection of data, technology, healthcare, and medical research, the potential it offers for all people, and the progress we're seeing in the drive to enhance human health and improve access to care. If you'd like to learn more, I encourage you to join us for the Precision Health track. In that track, we'll be taking a deep dive into several key topics, from the use of ambient intelligence in healthcare to the hospital of the future.